I don't know about you, Will, but if my students could stay this alert for this long, it would be fabulous. You're all my courses. I have a talk which I first gave. It's slightly in a different version, as you see, during the presidential campaign. I called it "Judging the Jumbled Jungle of Healthcare Financing Reform." That was the original title. I didn't usually have the pleasure of speaking after such lucid explanations of what healthcare reform is about. I was just speaking first. So I have an advantage tonight that I can build on what my colleagues have already talked about. But in general, I find, and I do this for a living, that understanding what's really out there and what really is being proposed is tricky. And part of that is because it's complex stuff inherently. Part of it is because I think there is an intentional obfuscation.
Yes.
And I will now confuse you to prove it. No. People who oppose reform introduce confusion. Death panel being the now classic example, instant classic. But even the people proposing the reform intentionally confuse audiences sometimes because they don't want to get into certain issues. They're too complicated, they're too scary, whatever. So I'm attempting to then, in this kind of a talk, to untangle the jumble a little bit and to help people understand it. The down to business part I added for today's talk, and it's intended to be a pun. Down to business because we're actually starting to do this after lots and lots of discussion, and it's really getting serious. But also down to business because I propose to you that what's being proposed is catering to business, essentially to the insurers. And I think we need to keep that in mind, understanding the limitations of where reform is going right now. I am from the Institute for Health Policy Studies at UCSF. In that capacity, I am a neutral, and I like to think on my best days, cogent observer of the healthcare system, if I'm lucky. I'm also president of the California Physicians Alliance, which is the state chapter of Physicians for a National Health Program. And in that capacity, I am acting to try to advance what I believe to be true from my research, which is that single-payer financing is the right way to go. I realize it's not on the table. The overview of my 15 minutes or so is to review key terms and concepts in healthcare financing reform to help you understand, to assess, and to participate in these debates. Maybe if we're really, really lucky, some of this will help you get into talk to Senator Feinstein and convince her to shift a little left. I'm going to talk about the current system, an overview of the system and some of its problems, and also I'm going to present to you two simple report cards on reform, what I call the Obama reform, which is a shorthand for all that is going on in the White House and in Congress, and on single payer. This is our current healthcare system. We have money, funds that come from employers, from premium contributions of individuals, from income taxes and out-of-pocket spending. That money goes to, it generally contributed to payers. The out-of-pocket part actually goes right across, but otherwise goes to payers. There are many private payers, there are insurance plans, and public payers, as we've heard earlier, Medicare, Medi-Cal, and other public payers constituted a very large part of our current system. In fact, if you add up all of the government contributions to healthcare in this country, we spend more in government money in this country per person than any country spends on healthcare, period. So we're already spending enough to have government-funded healthcare, we're just not getting it. The money that is here is in these private pools, and that part of the process of collecting the money is a little complicated, but what's really complicated is these next set of arrows. Getting the money from the payers to the providers is a tremendously complex process. There may be places like Maine where there aren't that many providers, but in good old California and in a lot of other places, each provider has to deal with lots and lots of payers. That means there are lots of different contracts to get paid, and there are lots of different processes which are not standardized despite some efforts to push us in that direction. And it's a very complex process. The net result is down here, which is that we're spending, let's say, roughly a fifth of our healthcare budget on administrative costs, depending how you define administrative costs, and I'll come back to that a little bit later. It's also useful to look at how the U.S. compares to other, usually the phrase is wealthy democracies, or OECD countries, countries in the Organization for Economic Cooperation and Development. And can anyone guess which of these lines is the United States? The trends are really, really striking. The U.S. used to be just barely at the top of the pack in the 70s, at which point the U.S. continued on its path and actually made a sort of a managed care transition. And in the meantime, our nearest neighbor, Canada, that's when Canada shifted to a single payer system at the provincial level. And Canada, I actually have trouble, even though I'm not colorblind, I have trouble finding all the lines here. I think Canada is right about there. So it's kind of at the upper third, but no one is close to us, except us. And it's getting worse in absolute difference, and proportionally, I think it's staying about the same proportionate difference. As advertised, I care a lot about administrative costs in healthcare. In fact, I just testified at a special meeting of the Institute of Medicine and the National Academy of Sciences, where my job was to present and then ultimately synthesize estimates of administrative costs in the U.S. healthcare system. We have some new data, some of which I was involved with, and some other colleagues as well. So now we can say with considerable confidence that we're spending about $400 billion with a B dollars each year in the United States on billing and insurance administration. Some of that money is insurance company profits. It's actually a small piece of it. More of it is insurance company administrative functions, but most of it is at providers. Doctors' offices, hospitals, pharmacies, etc. All of them have to deal with all these insurance companies. So just to give you one number, the doctors' offices are spending $1 of every 7 that they get just to get paid, 14%, right, by best estimate that I know. That's a lot of money to get paid. They're spending an additional 14% on regular administration like human resources and appointment clerks and stuff, but 14% or so to get paid. What does this work out to in terms of what each of you is spending? That works out to more than $1,000 per person per year just to move the money around the system. It is true, it's a one-time savings. As Will pointed out earlier, it's a big one-time savings. Well, so we spend a lot of money. What do we get for it? We rank 37th out of 191 WHO member states, putting us below Colombia and Portugal in terms of our health system. The Institute of Medicine previously estimated 18,000 excess deaths per year due to lack of health coverage. That's subsequently been up to about 21,000. People without insurance receive less medical care and receive it later. They have higher mortality, and when they're in hospitals, in the same hospital, they receive poorer quality care. Illness is a major cause of bankruptcy. The latest numbers, just came out earlier this year, suggest that roughly 60% of all bankruptcies involve either the problems associated with being sick and not working or medical debts. Those are a little bit hard to disentangle, but more than half due to medical problems, affecting more than 2 million Americans per year. Most of these individuals had insurance at the onset of the bankrupting illness.